Welcome to the Explainer. Today we're going to act as medical detectives to decode the incredibly dense, overlapping world of rare membrane amino acid transport disorders. Look, if you've ever stared at a massive list of metabolic diseases and thought, wow, these literally all sound exactly the same, believe me, you are not alone. It's a notoriously frustrating topic, right? Whether you're prepping for board exams or you're out there in clinical practice, it can feel like a total alphabet soup of strange symptoms and complex biochemistry. But today, we are cutting through that noise. We're going to break these conditions down by mapping them to their specific cellular geography. We are turning raw brute force memorization into pure logical deduction.
So, here is the central question we are answering today. How exactly do you spot a broken cellular gate? We'll be hunting for the distinct clues and those pathognomonic symptoms that tell us exactly which cellular gatekeeper has failed our patient. It's not about just memorizing endless, disconnected lists of clinical features. We want to deeply understand the why behind the presentation. We're basically going to trace the broken plumbing of the cell to figure out exactly why our patient is sick, working all the way from a microscopic defect up to a macroscopic systemic symptom.
Okay, here's our structured roadmap to separate these look-alike diseases. We've got 1. The cellular gatekeepers, 2. The two cysteine disorders, 3. The protein paradoxes, 4. The great pretender, and finally, 5. Master exam differentials. Let's jump right in.
Section 1. The cellular gatekeepers. Let's start by understanding the specific locations where these crucial transporters actually live, and why that matters so much. Think of membrane transporters as your essential cellular bouncers. They don't just float around randomly. They are stationed at very specific boundaries. Some are working at the luminal brush border of your proximal renal tubule or your intestine, basically facing the outside world and deciding what's allowed inside. Others are at the basolateral membrane, acting as the exit door to move things safely into the bloodstream. And some, they're deep inside the cell, guarding the delicate microenvironments of lysosomes or mitochondria. The crucial takeaway here is that when one of these specific bouncers fails, amino acids pile up exactly where they shouldn't be. And that localized traffic jam, that's what sparks a cascade of unique systemic failures. Moving to Section 2, the two cysteine disorders. Let's apply this geography concept to our first big diagnostic challenge.
Let's compare cystinuria against cystinosis. Notice how similar those names are? It's a classic trap, but medically speaking, they are worlds apart. Cystinuria is an apical or luminal brush border defect. The bouncers facing the urine fail to reabsorb dibasic amino acids, so cysteine just builds up in the kidney tubules. Cystinosis, on the other hand, is a lysosomal export defect. The bouncer inside the cell fails. This means cysteine successfully gets into the lysosome for processing, but then it can never leave. It gets hopelessly trapped inside the lysosomes of virtually every single organ in the entire body.
This brilliantly illustrates the presentation of cystinuria. Because cysteine is poorly soluble in regular urine, the excess simply clumps together, right there in the plumbing. It forms these striking, pathognomonic, hexagonal crystals and intensely painful, radio-opaque urinary stones. But here's the vital thing to remember. While those recurrent stones can absolutely lead to severe renal failure over time, cystinuria itself does not cause systemic cellular damage. The problem is isolated to the plumbing. The amino acids just never made it inside the body's internal environment in the first place.
Conversely, look at cystinosis. Because the defect is inside the lysosomes of all cells, it literally destroys the entire body from the inside out. In its classic form, it causes Fanconi syndrome in year 1. That's a massive, catastrophic failure of the proximal tubules leading to dangerous urinary wasting of essential molecules like glucose, phosphate, and amino acids. And beyond the kidneys, it deposits cysteine everywhere. It leaves these highly diagnostic corneal crystals you can actually see on a slit lamp exam, which cause intense, blinding photophobia for the patient. So understanding that specific mechanism gives us our exact treatment strategy for cystinuria. Since the issue is purely about cysteine solubility in the urine, our goal is simple: forcibly keep it dissolved. Step 1 is to dilute the urine massively, pushing more than 4 liters of fluid a day. And clinically, this requires a crucial, albeit incredibly annoying for the patient, dose right in the middle of the night to stop overnight crystallization. Step 2 is to bump the urinary pH above 7.5 using potassium citrate. Make it alkaline. If that isn't enough, Step 3 brings in a thiol drug, like penicillamine or tioprionine, to chemically bind the cysteine, forming highly soluble mixed disulfides.
Section 3. The protein paradoxes. Next, we are grouping together two metabolic mysteries where normal protein intake creates absolute biochemical chaos. Here we're contrasting lysine protein intolerance, or LPI, with citrullinemia type 2, which you'll usually hear called citrin deficiency. Now, LPI stems from a basolateral membrane defect affecting dibasic amino acids trying to enter the blood. Citrin deficiency, however, is an intermitochondrial membrane issue impairing the malate aspartate shuttle, the system that moves electrons across the mitochondrial membrane. They break completely different gates, right? But both of these defects severely disrupt the urea cycle, leading to dangerous toxic spikes in ammonia. And yet, they present with wildly different clinical pictures.
For LPI, your key diagnostic giveaway, aside from the impaired urea cycle causing extreme protein intolerance, is its devastating systemic complications. You'll see low plasma levels of lysine, arginine, and ornithine. But the real hallmark? The symptom that unequivocally separates LPI from every other amino acid transport disorder? It's a highly unique complication called pulmonary alveolar proteinosis, or PAP. The delicate air sacs of the lungs physically fill up with a thick protein-rich fluid, severely impairing breathing, and it presents alongside profound immune deficiency and early-onset osteoporosis.
And if you need a demographic hint to crack the case, lock this number into your memory: 1 in 60,000. Due to a profound founder effect, this condition is incredibly rare globally, but surprisingly common in Finland. So if an exam vignette or a patient history mentions a person of Finnish descent presenting with recurrent pneumonia and an extreme aversion to high-protein foods, LPI should immediately shoot to the absolute top of your differential list.
Now, check out this fascinating pathognomonic behavioral clue for citrin deficiency. Unlike LPI patients who get intensely sick from protein, citrin patients spontaneously crave meat and fat, and they strictly, almost instinctively, avoid carbohydrates. Why? Well, because their inner mitochondrial transport is broken. Carbohydrate metabolism generates cytoplasmic NADH that they simply cannot transport into the mitochondria to be processed, so their severe hyperammonemic attacks are actually triggered by things like high sugar intake, paracetamol, or alcohol. Their diet is literally their body's way of protecting itself.
Which brings us to a massive clinical pearl. If you are ever torn between citrin deficiency and a classic urea cycle defect on a test, or right there in the clinic, look closely at the glutamine levels. Classic UCDs have markedly elevated glutamine because the body is frantically trying to buffer the toxic buildup of ammonia. Citrin deficiency, however, presents with uniquely low or normal glutamine. That single lab value, combined with a strange craving for a high-fat diet, seals the diagnosis for you every single time.
All right, Section 4, The Great Pretender. Time to talk about the ultimate chameleon of the amino acid world, Hartnup disease.
Hartnup causes a luminal transport defect of neutral amino acids in the kidneys and the intestine. And because the intestines literally cannot absorb the essential amino acid tryptophan from food, the body can't synthesize niacin. This perfectly mimics dietary pellagra. I'm talking about the classic Ds, dermatitis, diarrhea, and the intense neurological delirium of dementia. It presents exactly like a severe vitamin deficiency, but the root cause has nothing at all to do with diet. It's a broken cellular gate.
What makes Hartnup so tricky is that most patients are completely asymptomatic for years. A patient might be doing just fine, living a totally normal life, until the disease is suddenly unmasked by physiological stressors that spike their metabolic demand. So watch out for triggers: a sudden high fever, intense sunlight exposure causing that classic photosensitive rash, severe psychological stress, or maybe the sudden introduction of sulfonamide antibiotics.
So how do we definitively unmask this pretender? Simple. We run a urine test. If a patient has pure dietary niacin deficiency, true pellagra, their urine amino acid profile is going to be completely normal. But if they have Hartnup disease, the urine test is going to reveal a massive neutral amino acid urea. We're talking a massive overflow of neutral and aromatic amino acids that the kidneys just failed to reabsorb. That overflow right there is your definitive diagnostic differentiator.
Section 5, Master Exam Differentials. Okay, let's bring it all together and synthesize these medical mysteries into your ultimate cheat codes.
Let's recap the trickiest differentiations, like cystinuria versus LPI. Both involve the exact same dibasic amino acids: lysine, arginine, ornithine. But remember our cellular geography. Cystinuria is an apical defect. The amino acids never leave the urine, causing isolated cystine stones with zero systemic toxicity. LPI is a basolateral defect. The amino acids successfully get into the cell but can't escape into the blood.
That means no urinary stones whatsoever, but a severely impaired urea cycle and devastating systemic effects, like that pulmonary alveolar proteinosis we talked about.
And this table perfectly illustrates the entire explainer in one simple matrix. Memorize these specific cellular locations in their linked pathognomonic symptoms, and you will master any board exam question on this. Apical defects, you get urinary stones or neutral aminoaciduria. Basolateral and mitochondrial defects, they disrupt the urea cycle and systemic metabolism. Lysosomal defects, intracellular crystal accumulation and widespread organ destruction. Match the symptom to the broken gate, and you solve the case.
As we wrap up this explainer, I want to leave you with a challenge for your next clinical rotation. If a patient presents with systemic crystal deposits, ask yourself, which cellular gatekeeper has failed them? Are you looking at crystals isolated in the urine? Or are you looking at crystals destroying the cornea and the lysosomes? And what does that precise location tell you about the failing plumbing inside? The geography of the cell never lies. You just have to know which broken gate to look for. Thanks so much for joining me on this one.